This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
Good morning. If you would take your seats, we'll get started with Grand Rounds today. Our speaker today is Dr. Patricia Wang, who is an assistant professor in pediatric nephrology here at the David Geffen School of Medicine and the Mattel Children's Hospital, UCLA. Dr. Wang received her medical degree from Mount Sinai School of Medicine and did her pediatric residency at Yale. She then returned to Mount Sinai to complete a fellowship in pediatric nephrology. She was faculty at an assistant professor level at Mount Sinai Hospital and then at Morgan Stanley Children's Hospital at New York Presbyterian before moving on here to UCLA. Her research interests are in the genetics of congenital anomalies of the kidney and urinary tract, and she was supported for her work by the National Kidney Foundation and an NICHD K-12 at Mount Sinai. She has authored about 6 peer-reviewed articles, a book chapter, and participated in various lectures and presentations. So the title of her talk today is Congenital Anomalies of the Kidney and Urinary Tract. So please welcome Dr. Patricia Wang to UCLA, a little late, but to the podium.
Okay, thank you. I'd like to thank the Department of Pediatrics for inviting me to give this talk. So the title of my talk is Congenital Anomalies of the Kidney and Urinary Tract. Oops. So the outline of my talk I'll first go through congenital anomalies of the kidney and urinary tract, also known as CAKUT, go through the definition, the epidemiology, and genetics, incorporating a little bit of embryology, and then talking more specifically about solitary kidneys and the epidemiology, pathophysiology, prognosis, and clinical monitoring of those patients with a solitary functioning kidney. And then at the end, if there's time, I'll go over some of my research project that I underwent when I was a fellow and an assistant professor in New York. So the clinical spectrum of CAKUT is very wide. It ranges from renal agenesis to dysplasia, to supernumerary kidneys, and in bilateral renal agenesis, it can lead to the Potter's sequence or Potter's facies, in which bilateral renal agenesis causes decreased urine output and lung hypoplasia, causing a decrease in amniotic fluid, and the uterine wall pressure will cause a typical Potter's facies, as seen here, with wide-spaced eyes and low-set ears, and also limb contractures and other limb abnormalities. The definition of CAKUT is wide, and it ranges from disorders in the kidney, the collecting system, bladder, and urethra. In the kidney, renal hypoplasia or dysplasia, also defined as decreased in kidney tissue and a disorganized dysfunctional tissue in the kidney, are the definitions of hypoplasia and dysplasia. Unilateral renal agenesis, which occurs in about 1 in 2,000 live births. Cystic dysplasia, 1 in 4,300 births. And a solitary functioning kidney, which is the most common type of CAKUT, occurs in 1 in 1,300 live births. Abnormalities in the collecting system, shown here, can range from hydronephrosis, megaureter UPJO or uteropelvic junction obstruction, and supernumerary collecting systems. And abnormalities in the bladder can be composed of uteroseals and vesicouteral reflux, also known as VUR. And then some people also incorporate disorders in the urethra, notably posterior urethral valves or PUV, under this heading of CAKUT. So the epidemiology of CAKUT is such that it's the leading cause of end-stage renal disease in the pediatric population. It affects about 1 in 600 live births, and that's based on various birth defect registries, and is present in over 20% of newborns that have chromosomal abnormalities. Some forms are part of a syndrome or associated with a family history, but most cases are sporadic and are isolated to the urinary system. Of note, CAKUT is thought to account for about 25% of end-stage renal disease in young adults in the 18 to 21 year age group, emphasizing the importance of smooth transition from the pediatric to the adult nephrology services. So CAKUT seems to be responsible for up to 30 to 50% of pediatric end-stage renal disease in the United States. Why is this important? Well, end-stage renal disease patients, 100% of them will need some sort of renal replacement therapy, such as kidney transplant or a modality of dialysis. And about 70% of these patients will go on to have hypertension and other issues related to the quality of life, including growth failure, psychosocial disorders, dietary restrictions, usually impact their quality of life, can have severe bone disease and cardiovascular disease. So to understand more about the etiology of CAKUT, we have to look at the genetics. And the genetics stem from familial aggregation studies that have been reported in about 10% of cases. However, most causes of CAKUT are not known yet. In the non-syndromic forms of CAKUT, there have been 3 genes that have been implicated in these forms of CAKUT that are non-syndromic. One is PAX2, one is HNF1B, and DSTYK. So I'll discuss PAX2 and HNF1B a little bit more in detail in the next few slides. But PAX2 is just a transcription factor. HNF1B is another transcription factor involved in the renal cyst and diabetes syndrome. And DSTYK is codes for a dual specificity serine threonine tyrosine kinase, which is known to be a positive regulator of fibrovascular factor in the developing kidney. So even though we know that CAKUT has a genetic component, mutations underlying isolated CAKUT has remained largely unknown. So different human syndromes associated to CAKUT. One that may be familiar to everyone here is Bardet-Biedl syndrome, where patients have obesity, diabetes, and can have polydactyly and retinitis pigmentosa, with their kidney phenotype being renal dysplasia and other calyceal malformations. There have been about 12 genes named from BBS1 to BBS12 that have so far been identified in the literature. Another one that is maybe familiar to everyone here is the branchio-otorenal syndrome, which is caused by the I's absence or EYA1, 6-1, and 6-5 genes, which all can cause branchio-otorenal syndrome where the renal phenotype is renal agenesis or renal dysplasia. These patients also have hearing loss and can present with auricular fistulas. Another one that is more common is the renal coloboma syndrome, which is caused by PAX2, which is part of the paired homeobox transcription factor genes. The gene PAX2 is expressed in the kidney, the ocular and the otic vesicles, and in the CNS. And these patients usually have renal hypoplasia, VUR, or multicystic dysplastic kidney. The patients 100% have some ocular abnormality, usually as ocular coloboma, but they can also have optic nerve dysplasia, optic nerve cysts, myopia, nystagmus, and different cataracts. A minority of these patients can have some high-frequency sensory neurohearing loss, which is often subtle and goes undetected. And then TCF2 is mutated in the renal cyst and diabetes syndrome, which has recently garnered more publicity in the news. These patients present with MODY, or maturity onset of diabetes of the young, and the renal phenotype is renal dysplasia and renal cysts. So the TCF2 gene is a critical regulator in the genetic cascade, which is essential to controlling the proliferation and differentiation of renal tubular cells. It also regulates the PKHD1 gene, which is mutated in autosomal recessive polycystic kidney disease, which accounts for the cystic phenotype in these patients. So just for the clinicians out there, some things to look for BOR, branchiootorenal syndrome, where the patients present with renal dysplasia and can have ear abnormalities. They can have an abnormal helix, antihelix, and tragus, which can often be subtle. Something that clinicians can also see is nail patella syndrome, which does often present with FSGS, but can infrequently present with VUR or renal hypoplasia. And an ear pit can often be the first sign that there is a renal abnormality, which is often can be subtle, but is something to look for in the newborn nursery. So there's a wide anatomical and histological spectrum of CAKUT, renal agenesis. This is polycystic kidney disease, horseshoe kidney, multicystic dysplastic kidney, and a bifid ureter. And so this wide spectrum leads us to think that even though that there is a wide phenotype of CAKUT, they all stem from a faulty renal development. So to understand more about the development of CAKUT, you have to look back at the genetics, and CAKUT is known to be multifactorial, which means that different genes and the environment work together to produce this phenotype. The different components of CAKUT, one of them can be abnormalities in the maternal diet. A low protein maternal diet has been known to be associated with low nephron number, which can be associated with renal hypoplasia and dysplasia. Age at birth, patients that are born prematurely can often present with renal dysplasia. Different ingestions, such as cocaine and alcohol, can also cause renal hypoplasia and dysplasia in the fetus. And maternal ingestion of common drugs such as NSAIDs, ACE inhibitors, anti-epileptics, immunoglycosides, also some immunosuppressive medicines such as mycophenolate mofetil or Salcept, and calcineurin inhibitors have been associated with a low nephron number in the fetus. So the thought is that CAKUT is a complex trait. And by complex trait, we mean that it is caused by more than one gene and possibly by environmental factors. A monogenic or Mendelian disease is usually caused by one gene, such as cystic fibrosis, which is caused by the CFTR gene, and sickle cell anemia. They're usually rare, but that's not always the case. And mutations in a single gene is usually responsible for causing the disease. The environment and the polygenic background usually has little or no role in the patient. Thank you. Thanks. So CAKUT as a complex trait, the thought is that there's most likely a polygenic inheritance, and that there is some influence of the environment, and that plays a role in the development and expression of the genes that are involved in this disease. So to understand more about the genetics and how CAKUT actually develops, we do have to go over a little bit of embryology, as you all remember from medical school. Embryology of the kidney, it starts off with the pronephros, the mesonephros, and the metanephros. So the pronephros is basically non-functional. It takes no part in filtration of any toxins or in filtering the blood. The mesonephros and the metanephros are both functional units of the kidney. The mesonephros ends up developing the mesonephric duct, which in turn becomes the ureteric bud. So you see here in this picture, there's the pronephros, mesonephros, and the metanephros. So an outpouching of the mesonephros is here, shown here, It becomes a ureteric bud, which then invaginates into the metanephric mesenchyme here, shown in light pink. This causes epithelialization and inductive reciprocal signaling from the ureteric bud and the metanephric mesenchyme, which then causes branching morphogenesis. And this is how the kidney is slowly formed. Eventually, there are about 500,000 to 1 million nephrons in the human kidney. This is just an average. There are people that have less and some people that have more nephron endowment. So again, going over the pronephrodes, it's considered non-functional. It usually develops in the cervical region at day 22 of human gestation. And as I said before, the pronephric duct in the embryo, and it can't filter materials outside of the embryo and eventually degenerates. The mesonephros is known to be functional. It develops at the end of the 4th week, and it produces urine between weeks 6 and 10. That's an overall average. For the board's answer is 9 weeks. But the mesonephros usually ends up forming the mesonephric tubules, which degenerates and leaves behind the mesonephric duct, also known as the Wolffian duct, which gives rise in males to the epididymis, the vas deferens, and the seminiferous tubules. The mesonephric duct ends up becoming the ureteric bud, and that forms the ureter, the pelvis, the major and minor calyces, and the collecting tubules. So the metanephros really becomes the permanent kidney, and it starts developing at week 5 of the embryonic period. So you can see here in this cartoon, the ureteric bud forms the collecting system by forming first a renal vesicle through epithelialization. That in turn forms this comma-shaped body and S-shaped body over here that then connect together and form into the collecting duct. The endothelial cells here then migrate over to the S-shaped body, and they begin to condense and form the glomerulus. Here you can see this elongates into the collecting duct, and then you form the loop of Henle, the distal tubule, the proximal tubule. So talking about reciprocal induction from different experimental knockout models, different genes that have been implicated in renal development are known. You can see here in the blue, there's the metanephric mesenchyme, and the different genes that are involved. Like I said before, there's EYA1, Eyes-absence-1, implicated in branchiootorenal syndrome, PAX2, and renal coloboma syndrome. And the Wolffian duct, or the nephric duct, is here. One of the genes expressed is RET, and its receptor is GD and F. So the Wolffian duct evaginates, like I said before, forms the ureteric bud. It then forms epithelialization and condensation through reciprocal induction signaling between these genes and the genes in the metanephric mesenchyme. And this then causes the distal ureteric bud to proliferate, epithelialize, and then form eventually the glomerulus and the different parts of the kidney. So any perturbation of expression of these genes can cause a problem in the kidney and eventually cause a congenital anomaly, as I will show you in the next few slides. This is a schematic of the normal kidney development. The pronephros, again, regresses by 4 weeks. The mesonephros gives rise to the mesonephric tubule and the duct. The mesonephric tubule eventually degenerates. The mesonephric duct, also known as the Wolffian duct, will then give rise to the ureteric bud. And this ureteric bud in males and females will give rise to the collecting ducts, the renal pelvis, and the bladder trigone, and form part of the functioning mature kidney. Through reciprocal interactions between the UB, the ureteric bud, and the metanephric mesenchyme, the nephrons are made, and through differentiation, epithelialization, the functional mature kidney is created. So I went through the embryology a few times just to make sure that everyone understands how important that these interactions between the mesonephric duct and the metanephric mesenchyme are for the eventual formation of the functioning mature kidney. You can see here in this cartoon, if you have abnormal interactions between the mesonephric duct and the metanephric mesenchyme, you get renal agenesis. If there is abnormal gene signaling in the ureteric bud where it branches into the metanephric mesenchyme, you'll get again a hypoplastic kidney, multicystic dysplastic kidney, UPJO. You can get VUR with hydronephrosis. You can also get a double ureter. So some anomalies of the urinary system, just to show you a pictorial. If you have an absence of the ureteric bud, so the metanephric mesenchyme does not interact at all with the ureteric bud as shown before, you end up getting unilateral renal agenesis. If you get incomplete division of the ureteric bud, and then the ureteric bud gives rise to the ureters, the renal pelvis, the bladder trigone, everything from the collecting tubules downwards is responsible from the ureteric bud. You can get a pelvic kidney, seen here, and you get a divided kidney with a bifid ureter, right here. If you have complete division of the ureteric bud, you can eventually get a double kidney. We have malrotation of one kidney where the kidney hilum faces anteriorly. And you can also get a bifid ureter again and a double kidney. If you have migration of the left kidney to the contralateral side, you can get cross-renal ectopia here with the ureters crossing over to the right side. And a few more examples. A pancake or a discoid kidney usually results when the kidney fuses while it is still in the pelvis. And so you have fusion of the kidneys here, pancake or discoid kidney seen here, and it fails to ascend during development. And then if you have two ureteric buds, you don't have a bifid ureter, but you have instead two separate ureters and two kidneys. So summary of the kidney development part. Human renal development begins at the 5th gestational week. It's characterized by complex interactions between the ureteric bud, which is responsible, again, for the pelvis, renal pelvis, the ureter, and the lower urinary tract development, including the bladder trigone, and the metanephric mesenchyme, which is responsible for development of the renal parenchyma, including the proximal and distal tubules and the loop of Henle. And nephron formation is not complete until between the 34th and the 36th week of gestation. Total number of nephrons can range from 500,000 to 1 million per kidney and should last the entire lifespan. And any abnormal interaction between this ureteric bud and the metanephric mesenchyme can result in the CAKUT phenotype. And different environmental factors have been implicated in this phenotype. So I want to go more in depth into the clinical and the biological aspects of a solitary kidney, since it is one of the most common features of one of the most common types of CAKUT. It can be either congenital or acquired, and congenital is about 1 in 1,300 live births. Acquired is from a unilateral nephrectomy. However, both types are associated with chronic kidney disease. And a third of the patients with congenital solitary kidneys also have ipsilateral CAKUT, meaning that on that side, they also have concurrent VUR, UPJO, megaureter, or duplex kidney, or other different anomalies of the kidney, which can complicate the picture and make preservation of their kidney function even more challenging. Most of these patients are identified before birth now with routine fetal ultrasounds. So the question that a lot of people have about solitary kidneys is regarding prognosis and clinical monitoring. This is just a schematic of what we think is the pathophysiology behind a solitary functioning kidney. So a solitary functioning kidney, by definition, has reduced renal mass. Even if you have compensatory hypertrophy of that solitary kidney, you still have a reduced nephron endowment than if you had two normal functioning kidneys. So if you have any additional factors such as CAKUT, VUR, hypoplasia, dysplasia, UPJO in that kidney, it can complicate the picture. Genetic factors are involved, and environmental factors such as IUGR, premature birth, nephrotoxic drugs, presumably given in the NICU, or other environmental factors such as NSAIDs and aminoglycosides, like I said before, ACE inhibitors that are ingested during pregnancy. An increased BMI in the mother can also cause a congenital solitary functioning kidney. So this reduction in renal mass, it is a decrease in nephron number, and from the decrease in nephron number, the thought is that there will be the increase in nephron size and kidney size puts a stress-induced glomerular cell, causes stress-induced glomerular cell activation, fibrosis, and vasoconstriction, which will eventually cause glomerular hypertension and glomerular hyperfiltration. Glomerular hyperfiltration will eventually cause a glomerular sclerosis secondary to the vasoconstriction and the fibrosis and the increased pressure in the glomerulus. And this will also cause a catch-22, where the glomerular sclerosis will then cause another reduction in renal mass, and the cycle continues. The glomerular hyperfiltration is probably secondary to the glomerular enlargement, increased glomerular pressure, and it's probably beneficial at birth. However, long-term, this glomerular hyperfiltration and eventual compensatory hypertrophy of that solitary kidney will eventually lead to glomerular sclerosis and what we think is hypertension, proteinuria, and decline in GFR long-term. This is usually in the adult population and doesn't manifest clinically in the pediatric population. So there's a theoretical difference between patients that have a congenital versus acquired solitary functioning kidney. The thought is that the congenital solitary functioning kidney occurs at about 22 weeks of gestation. So there is potentially time to form new nephrons, since the kidney does not complete its nephrogenesis until about 34 to 36 weeks of gestation. The acquired type is done when nephrogenesis is complete at the time of nephrectomy. So the hypothesis is that there's a higher susceptibility for this glomerular hyperfiltration in acquired solitary functioning kidney patients than in congenital. So in our daily clinical practice, the outcome of patients with congenital functioning solitary kidneys is usually derived from the excellent prognosis of adults that have donated a kidney. However, it's hard to make the comparison between the congenital and acquired solitary functioning kidney patients in this regard, because these patients that donate a kidney are usually undergo a very stringent health screening and are very, very healthy, and some patients with congenital solitary functioning kidneys do have concurrent ipsilateral CAKUT, such as VUR, that goes undetected, or renal dysplasia that may be microscopic. So this is still up for debate, but the thought of that there is a difference between congenital solitary functioning kidneys and acquired is still being debated, and that there is a difference in the risk of progression to chronic kidney disease. So there's really been a lack of good long-term studies about the clinical outcome of solitary kidneys. The one study that was done in the lab I used to work at in New York was a longitudinal study published in 2009, which looked at about 300 patients with CAKUT until the age of 30 years. The average follow-up time was about 5 to 6 years. 58 of these patients eventually started dialysis. And the risk for dialysis was significantly higher for solitary kidney compared with unilateral or bilateral hypodysplasia. You can see here on this graph, on the y-axis, survival probability, on the x-axis, age in years. What's actually also notable is that with the exception of bilateral hypodysplasia and post-urethral valves, most patients did not actually undergo a decline in their renal function until late adolescence. And the patients, like I said before, with bilateral hypodysplasia actually did not progress to end-stage renal disease any faster than those with solitary kidney, which is something that I think would be surprising to a lot of nephrologists, because the thinking is usually that solitary kidney patients usually do very well and don't need follow-up. The opinion about why the patients with solitary kidney actually have a worse outcome than those with horseshoe kidney, unilateral hypodysplasia, or bilateral hypodysplasia is that they usually don't get proper follow-up and are not told they have a renal disease and are not characterized as having chronic kidney disease. So they may go years and years with hypertension and proteinuria and not know it, and eventually present an end-stage disease in their later adulthood. So risk factors for CKD in patients with a solitary kidney, like I said before, patients with an ipsilateral CAKUT or have small renal size, socioeconomic, lower income and maternal education, and some clinical factors such as short stature. They have hyperphosphatemia, anemia, abnormalities in their lab work, history of UTIs, prematurity, and low birth weight. The guidelines for follow-up of solitary kidneys, this is taken from a study that was done in Belgium. And I mean, I'm not in complete agreement about their guidelines, but every patient is a little bit different. But in general, if there's a solitary, isolated solitary kidney without concurrent CAKUT, the thinking is that if they have no reduction in their GFR, that they can get their blood pressure monitored annually, get microalbuminuria studies annually, and then just monitor with ultrasounds and serum creatinine every 5 years. If they have concurrent CAKUT, then the thinking is to get a blood pressure reading every 6 months and urine studies every 6 months with serum creatinine every 5 and an ultrasound as needed. If they have any reduction in their GFR or proteinuria or hypertension, they should be followed a little bit more closely about every 3 to 6 months for blood pressure, urine studies, and for serum creatinine. This table is definitely very modifiable, and every patient really needs to be taken individually. So the management of solitary kidneys, some things which seem obvious: avoidance of NSAIDs, aminoglycosides, and any nephrotoxic medications. You can use ACE inhibitors, which can decrease the amount of proteinuria, since proteinuria is associated with a rapid decline or increasing decline in renal function. These patients during their pubertal growth spurt need to be watched a little bit more carefully. Dietary management with obesity and protein restriction, since this can put an undue stress onto the kidney. And definitely monitoring long-term with hypertension and microalbuminuria. So I was going to talk a little bit about vesicoureteral reflux, or VUR, which was part of my research project as a fellow and as a junior faculty in New York. I looked at vesicoureteral reflux, and similar to CAKUT, genetic basis was seen initially in 1955 in VUR based on a set of fraternal twins. There is a higher sibling recurrence risk of 25 to 40%, and there's concordance in monozygotic twins of 80 to 100% versus 35 to 50% for dizygotic twins. And different segregation analyses done over 30 years ago determined that the most likely model of VUR is probably autosomal dominant with reduced penetrance. However, there's some difficulties in studying VUR. The most common problem we encounter was that there's spontaneous resolution with age, so it's very difficult to actually characterize which patients had the disease and which didn't. In addition, the severity of VUR really differs between affected individuals in a family. Some patients would have just grade 1 VUR, and some would present in end stage without ever having a urinary tract infection, and the thought was they had VUR based on DMSA scans. It's also very difficult to screen these patients because asymptomatic individuals, it's hard to convince them to get a VCUG. It's traumatic, invasive, it causes undue stress, and it's radiation. So, taking that with a grain of salt, this I kind of went over. So the project was, I collaborated with different investigators in Italy and New York. I spent a good number of weeks of my fellowship in Italy recruiting patients, which is a wonderful way to spend part of your fellowship. I went to University of Brescia and Genoa. Brescia is right outside of Milan, and I was working at Columbia at the time, and I established some collaborations with the urologists at NYU, at Mount Sinai, and at Montefiore. We were looking at families from the Hasidic Jewish community, since these individuals, there was a very small inflow and outflow of new genes in this community. It was a very small community, and they had very large extended pedigrees. So what we did was we ascertained through an index case of VUR documented by positive VCG, and then additional family members were recruited to the study if they had either primary VUR documented by VCG or other urinary tract anomalies with or without VUR. all other individuals were considered phenotype unknown, not as unaffected, since they could have had reflux at a young age and then had it resolve. So I looked at 16 different pedigrees, and DNA was collected from 200 individuals. 72 were affected patients, and 11 individuals had other urinary tract anomalies. You can see here of note that there were nine families that had affected individuals in multiple generations, suggesting an autosomal dominant inheritance pattern. You can see here, right here, in K120, K143. And then an additional 9 families, there were only affected individuals in one generation, suggesting autosomal recessive inheritance pattern. And then about 7 families, there was a lack of male-to-male transmission, X-linked transmission could not be ruled out. So you can see here, like in this family, there were every single child in this generation was affected with VUR, documented by a VCUG. So the thinking was that there was possibly also something in the environment that was related, especially to this family. These were all Hasidic Jewish families from a very small community in upstate New York. So we did a genome-wide scan looking at with microsatellites and SNPs. We looked at about 400 markers in all 200 individuals, and then chose about 95 individuals just based on funding. We chose to do genome-wide scan with a 10K chip. We did different analyses of linkage. And just to quickly go over, so everyone is on board about linkage and LOD scores. We genotype a marker. This is a real marker on a microsatellite on chromosome 3. The microsatellite is made up of a small repeat sequence of DNA that's repeated numerous times, and it has different allelic forms. As you can see here, the allele 5 segregates with the disease phenotype. And then you do, through different computer and analytical programs, you can then calculate the LOD score. So LOD score is a method of measuring linkage. It's log to the base 10 of the likelihood of the odds ratio. So it's a statistic that quantifies the probability that you are observing co-segregation of the marker, the allele, with the marker with the phenotype based on chance versus on actual linkage. So if you have an odds ratio of 1,000 to 1, this corresponds to a LOD score of 3. And generally the thought is for complex traits, a LOD score over 3.3 makes you about 99% sure that you are in the correct region where the gene of interest lies. The nice part of the LOD score is that you can actually add LOD scores together for different families to try to increase your LOD score to achieve significance. So for instance, I'll show you first the clinical data. So the clinical data that we had for our 16 pedigrees and 200 individuals, we had 22 male and 50 female that had primary VUR, and 11 had other related abnormalities. We had 111 that were Ashkenazi Jewish, 73 Italian, and 16 Irish, and that had some Italian and Irish background. And then 4 presented in chronic renal failure, and 18 had surgery or a deflux procedure. The other urinary tract anomalies you can see are listed here. A couple of them had UPJO, uropelvic junction obstruction, hydronephrosis, ectopic kidneys, renal hypoplasia, ectopic kidneys, duplicated collecting system, and 4 actually just presented in end stage of unknown etiology. A couple of them had a history of VUR and underwent surgical repair. So we did a genome-wide scan. I'm not sure if you can see it from the back, but here is listed from chromosome 1, 2, 3, 4, 5, 6, 7, 8, etc., until chromosome X at the bottom. This is the line for the lot score, and the dotted line here is our lot scores that we achieved for our families. So you can see that basically it was completely flat. There was nothing of significance under the autosomal dominant model. With the autosomal recessive model, there was a peak here, suggestive. We had a lot score under heterogeneity, thinking that there's most likely more than one gene involved in this disease, similar to like breast cancer. There's BRCA1, BRCA2, multiple genes involved in breast cancer. There's probably multiple genes involved in VUR. So we found a lot score of 2.5, which is suggestive of linkage, but like I said, about a lot score of 3 to 3.3 is needed for significance. I fine mapped with more markers, and we achieved a lot score significance of 3.6, thinking that our gene is in this area of chromosome 12. Here again, you can see in this picture, the graph, there's on the y-axis is the lot score, on the x-axis is the distance in megabases. I did different analyses, basically looking at the solid line is primary reflux, and then the dotted line is reflux plus other urinary tract anomalies. And so we did achieve over a lot score of 3 for both of these phenotypes. So the lot score, we also did something called a non-parametric linkage score, which we calculate the linkage without putting into the computer what we thought the mode of transmission was, autosomal dominant or recessive. The computer basically calculated out what they thought the lot score would be, and it was 4.0, which is equivalent to about a p-value 1 × 10⁻⁴. So there most likely was there is something in this area on chromosome 12p11q13. So we've isolated an area on chromosome 12. However, it's very large, and there are 64 genes in this area, and it's would take a lot of money and time to sequence every single gene there to look for a mutation. So different modalities of trying to narrow down this region are to do exome sequencing, association studies, other different tests, different genetic tests to try to narrow down the area, or you can also recruit more families. So then I recruited a couple of other families back in New York. Here you can see some affected individuals. There's some consanguinity here. You can see here there's this child was the index case of VUR, and there's consanguinity, and then there are multiple affected members in the family. So the analysis of these families is still ongoing. Here's another consanguineous Jewish family I recruited a few months before I came out to UCLA. So it's important just to screen apparently sporadic patients and to question on your history and physical exam. This is an index case of renal hypodysplasia. The dad described that he was diagnosed at age 12 by accident. He wasn't really sure what the circumstances were, but he was diagnosed with renal hypodysplasia. Mom died at age greater than 80. He was on hemodialysis. The thought was possibly the patient had diabetes and hypertension, and the son had renal hypodysplasia by history. So upon more questioning, we got this huge family history. The family size was 177 individuals, and through different clinical and imaging studies, we found that there are about 40 individuals we wanted to get their blood on. And after characterization and a very detailed, laborious discussions with the family and many trips over to Italy, we found this family. In Italy, we found that the other side of the family, there were multiple affected members here. This family, this horizontal line here is significant for just small kidneys, so we weren't sure if that was diagnostic of CAKUT or not. But there eventually were 12 patients in this family that had renal anomalies. There were 15 unaffected. They had undergone screening with renal ultrasounds, and then 13 were unknown. So it's just important to ask for all patients that you think have just isolated non-familial CAKUT or renal hypodysplasia or VUR or any renal abnormality, just to question them very thoroughly. And sometimes they will say, oh yeah, I have a second cousin or a great-grandmother that died on dialysis. And then from there you can go further. So the analysis of this new cohort of VUR basically is still ongoing. We have narrowed down the region on chromosome 12, but there are still a lot of genes in the area. None of them seem to be involved or expressed in early kidney development, so the research is still ongoing. So future studies is to recruit new cohorts and do some further genetic analyses. If you know any patients, you can definitely give me a ring at my email. And that's it. I'd just like to acknowledge my mentors over at Columbia and at Mount Sinai, where I did my fellowship. Thank you.